This is case L3 CT A50. The history is that of a 57-year-old gentleman who had new onset of atrial fibrillation, was admitted to the hospital, received successful cardioversion, and prior to discharge, it was requested that he get a CT coronary arteriogram. We start first with inspection of the study. We're now at the base of the heart. The ascending aorta and the descending thoracic aorta appear to be of normal size. In particular, we want to be sure that the left atrial appendage appears to be normal. This patient has had recent atrial fibrillation, and the left atrial appendage does in fact appear to be without thrombus. So we move down lower. Here's his left atrium. One of the concerns might be that the left atrium might have been dilated. If we make a measurement, roughly using a traditional M-mode echo method, we find that the overall left atrial size remains in the normal range. Continuing down further, thoracic aorta is normal. There's no evidence of pericardial fluid. The pericardium is of normal size. Examining the global left ventricular function, here is a horizontal long axis view. Examining the function, seems to be reasonable function involving the septum, apex, and lateral wall. If we look at the vertical long axis view, anterior wall, apical and inferior wall, there may be some suggestion that the overall global EF is somewhat on the low normal range. If we then proceed to a short axis view, we can see that there continues to be overall normal function, although a suggestion that the global EF may be somewhat in the low normal range. We want to look also at the overall left ventricular chamber dimensions. This is the short axis view. We can go and try to make a traditional M-mode type measurement and the end diastolic frame. We're getting about 50 to 52 millimeters. Upper limits of normal is 55 millimeters. Examining the coronary arteries, here is the left main coronary artery. It appears to be normal. There's always a potential that there could be some mild non-calcified plaque in the region. Sometimes it's easy to determine. Most of the time it's quite difficult. Motion artifacts can cause various problems, and there's certainly nothing obvious in this individual. If we examine the left anterior descending, we see that the proximal segment demonstrates some extraluminal material that appears to be on the order of the same density as the contrast media. This raises the possibility of an ulcerated or dissected plaque in the region. However, the lumen does not appear to be compromised. So this is moderate eccentric plaque consistent with ulceration or dissection. The remainder of the left anterior descending artery appears to be basically normal all the way down through the apex. We go back and examine the circumflex artery coming off here. This appears to be very normal. No evidence of any problems involving the left circumflex. Finally, we examine the right coronary artery coming off in this region. Again, appears to be very normal. Sometimes it's difficult to determine if there's any potential for non-calcified plaque, but the vessel appears to be grossly normal. If we look at the bottom surface, we can see a portion of the posterior descending artery. So in summary, we have a 57-year-old gentleman who's had new onset atrial fibrillation with successful cardioversion. His overall left ventricular size is normal. Global EF may be borderline no. It measured at approximately 55%. There is no evidence of left atrial appendage thrombus. The coronary arteries demonstrate the presence of eccentric, non-obstructive, possibly ulcerated plaque in the proximal left anterior descending artery, and the remainder of the coronary arteries are normal.